Dear students, you are again welcome to another topic, and my name is Moses Wanchiri. What we are going to discuss today are affective disorders, and we are going to follow the following outline. Our objective one is that by the end of this discussion, you are expected to be able to define affective disorders. You are also expected to be able to describe the causes of affective disorders. You are also expected to be able to describe the signs and symptoms of affective disorder. And at the same time, you are expected to be able to describe the management of a person with affective disorder. Now, as you have seen, we have a word called affective disorder. The word affect actually means mood. Although these words are used interchangeably, they have a slight difference, and I'm going to explain it shortly. Mood means the inward feeling of a patient. For example, if you asked one that, how do you feel in your heart? And then the person tells you, I'm feeling happy. That is the mood. And the outward appearance that the person has because of the inward feeling of the mood is the affect. So we can see the affect, but we cannot see the mood. So the mood is reported, the affect is observed. So we are saying that the word affect means mood. They are used interchangeably, but I think now you have got the difference. Now, affective disorders or mood disorders are mental illnesses in which the disturbance of mood constitutes the dominant feature or the dominant clinical feature of the illness. There is disturbance of what? Of mood. That's why they are called mood disorders. So the psychopathological changes of mood disorders include three forms. One, we may have recurrent episodes of mania, or we can have depression, or on the other hand, we may have alternating episodes of mania and depression. And therefore, there are three clinical psychiatric episodes of affective disorders. And these three psychiatric clinical episodes of affective disorders can occur in a severe form, they can occur in a moderate or a mild form. So the first psychiatric episode is called the manic episode. The manic episode is when the person has elevated mood, they have increased physical energy, they have increased mental energy, and this increased physical and mental energy may occur with or without psychotic symptoms. In other words, we are meaning that they can occur with delusions and hallucinations, or they may occur without delusions and hallucinations. The next one is the depressive episode. The depressive episode is characterized by persistent sadness, hopelessness, loss of energy, and loss of interest in previously pleasurable activities, and sometimes it is also accompanied by low self-esteem. And that is the second episode, which we are calling depressive episode. And then we may have episodes that may be alternating. They may be alternating and therefore called bipolar affective disorders. Bi means two, and this time we are saying bipoles, bipolar affective disorder. In other words, it occurs with episodes of mania at one time, and then it also occurs with episodes of depression at another time. Now, I'm going to define what bipolar affective disorders are, or what we call a bipolar affective disorder. And this statement is sometimes confusing. I request you to take a little bit of attention. And I'm saying a bipolar affective disorder is a disorder which occurs with mania, with or without depression. Are episodes of mania with or without depression. But we've been saying that they occur with depression, mania, depression, mania, depression. But in the definition we are saying is when a person has episodes of mania with or without depression. Maybe let me demonstrate this diagrammatically. For example, if we have episodes of mania followed by mania, followed by mania, followed by mania, we call that a bipolar affective disorder. But at the same time, we may have episodes of mania followed by depression, followed by mania, followed by depression. This one also will be called bipolar affective disorder. But at the same time, we may have episodes of depression, followed by episodes of depression, followed by episodes of depression, followed by episode of depression. This one is not bipolar. It is actually depression. Yeah? It is unipolar depression. So, in my definition, I said a bipolar affective disorder is when we have episodes of mania with or without depression. So that means that episodes of mania means bipolar. But when we have episode of mania followed by depression, still it is called bipolar. The reason being that sometimes episodes of depression, in this first case, episodes of depression usually go unnoticed. And therefore, even if we had mania, we are right to say that is a bipolar affective disorder. Even if we had mania and an obvious episode of depression, it is also called bipolar. But if we have episodes of depression, it is depression. Okay, maybe at this point, we have a concept of what we call bipolar 1 and bipolar 2. Bipolar 1 disorder is when a person has symptoms to meet a full criteria for a manic episode, but then he does not have experiences of depression. So, if a person has symptoms of mania without any experience of depression, then that is bipolar 1. And in this case, the manic episode that we are talking about has the following symptoms. It may be having at least three or more. That means 3 or more of the following symptoms. We have increased talkativeness. We have increased self-esteem, sometimes what they refer to as grandiosity. Grandiosity is inflated self-esteem. We have decreased need to sleep. We have increased goal-directed activities. These people have high energy levels, and sometimes you cannot avoid irritability. They are sometimes irritable. These people also have racing thoughts. Now, racing thoughts is a rapid thought pattern. And this rapid thought pattern is not just a fast thinking, but we are talking of rapid. That's what we are referring to as racing thoughts. Then we have poor attention. These people cannot pay attention on one thing. And then we have increased risk taking behavior. Things like overspending of money, risk sexual behavior, all those ones describe this manic episode. So bipolar 1, we are saying, is a disorder that has symptoms that meet full criteria of diagnosis of an episode of mania. And then there are no experiences of what? Of a depressive episode. And then the bipolar 2 is when a person has had experience of depression or a depressive episode with a less severe form of mania. This person this time has episode of depression, but with a less severe form of mania. This less severe form of mania actually is called hypomania. It's called hypomania. So in other words, we can call this one to be bipolar 1. And this one, okay, if we are to name these ones A, B, and C, A can be described as bipolar 1. And then B is bipolar 2, especially if there is a depressive episode, but this manic episode is of the type of hypomania. And in this case, the depressive episode we are describing has the following symptoms. The person has a persistent depressive mood. There is change in sleep. This change in sleep can be excessive sleeping, or it can be even lack of what? Lack of sleep. Then the person may have changes in eating habits. Some people eat a lot when they are depressed, and others may lack appetite completely when they are depressed. The person may have fatigue, or lack of energy. They may have lack of pleasure in previously pleasurable activities, or lack of pleasure in the activities they used to enjoy before. Then there is restlessness, or the person slows down in action, and then feeling of guilt or worthlessness. And then there is indecisiveness and difficulty to concentrate. The person cannot follow the chronology of events. He cannot concentrate, in other words. Then they have also suicidal thoughts. So that is the concept of the bipolar 1 and the bipolar 2. Then let us talk about the causes of affective disorders. Now, the genetic predisposition is highly implicated in the causation of affective disorders. But as we said earlier in other mental illnesses like schizophrenia, when we say genetic, we usually imply that there is a gene that is involved. But in this case, there is no gene that is implicated in the causation of schizophrenia. However, the genetic factor influences the one's capacity or ability to produce neurotransmitters that are responsible for the causation of these bipolar the affective disorders. For example, the neurotransmitters that are implicated in the causation of affective disorders are norepinephrine and then serotonin. So, the one's ability to produce varying levels of these neurotransmitters can be genetically predisposed, or it can be passed on from parent to offspring. But remember, there is no gene that is exactly implicated in the carrying of this the affective disorders. However, the onset of an episode can be precipitated by stressful life events or stressful situations. So there is a stressful life event that occurs just before the person breaks down. However, the predisposing factor could be that is genetic, and the genetic predisposing factor could be the one's ability to produce varying levels, either too much or too little of the neurotransmitter. In this case, we have norepinephrine and serotonin neurotransmitters. Okay, let us talk about the clinical features, this time of a manic episode. We've been discussing affective disorders generally. We described the manic episode, we described the depressive episode, and we've been describing bipolar affective disorder, whereby we also talked about the concept of the bipolar 1 and bipolar 2. And now we are going to the clinical symptoms of a manic episode, or clinical symptoms of clinical feature of mania. Now, hypomania is a term that is used to describe a mild form of a manic episode. And in this one, there is persistent elevation of mood, there is overactivity, but in this case, there are no psychotic features. In a hypomanic episode, there are no psychotic features. Probably if I'm to describe this hypomanic episode, so many people who have hypomania are living in the community without being diagnosed and therefore not being treated, simply because these people are mistaken for being very clever. They are sometimes mistaken for being very active people, very hardworking people, because they have high mental energy and high physical energy. I think you have heard of certain times when they say that person ran mad because of being very clever, because of excessive intelligence. That's what made him to become mentally ill. No. The issue is, by the time they are considering this person to be very clever, very intelligent, they are actually having the disease already. And they are having what you see at that time is the high mental energy and physical energy at that point. And if it is in the family, you know, sometimes this one usually starts during when a person is growing, the body is changing, and there are also different hormones that are being produced in the body, the development of various hormones in the body. This is when it strikes. At a time when a parent is even thinking, oh, this is my hair, is when it strikes. And at that time, the person is active. He thinks beyond the others. He's acting. He does this, he does the other. And at that time, they consider him to be very clever, or sometimes very bright. And then, when the symptom becomes severe, with a stressful event that may be sometimes exams, the person now breaks down. And when the person breaks down, then they start saying, oh, that one, you know, they put medicine on the chair, and therefore they bewitched him because they never wanted him to win, to be the best student. No. The thing is, by the time they are considering this person to be very clever, is actually sick, but is having a mild form of mania, which is hypomania, which is characterized with high mental energy and high physical energy. Now, mania refers to a severe form of the illness, and it is characterized by extreme overactivity. It is also characterized by overexcitement, and the person this time may have psychotic symptoms, unlike in hypomania, when we do not have psychotic symptoms. Now, let us describe the individual clinical features of mania stroke hypomania. Remember, they are all the same. Hypomania is a mild form. Severe one is mania. So we are describing the clinical feature, but these clinical features, depending on the severity, they can be for mania, and if they are mild, they can be for hypomania. So, one of the clinical features is elevation of mood, in which the patient has elevated mood, which is sometimes referred to as euphoria. Euphoria is exaggerated sense of well-being. For people who have taken some alcohol, beer, that time when a person is about to get drunk, that is when we have euphoria. So that is euphoria. So that person, this time he has not taken anything, but he has that elated mood, which is described as euphoria. The person is cheerful. He feels on top of the world and optimistic. Optimism is when the person feels there is no obstacle very hard to overcome in future. The future is bright. The future has a lot to offer. That is a person becoming optimistic. These people are high in spirit, but then they can easily become irritable. They easily become irritable, angry, and sometimes aggressive if their plans are frustrated. In fact, these are people who are always having plans that are beyond their capacity. And should anybody comment that probably you may not be able to complete this, the person may say, I want to build a perfume factory at State Square. And then you are like, do you own that land? Then if you don't own the land, then you can't build there. Do you have the money? He says, now, who are you who is interfering with my plans? Then they become irritable. They become angry. Then they can even become aggressive and violent at the same time. These patients also have overactivity, and in this overactivity, they become restless. They are always on the move, and they do things always at a rush, even when there is no need for rushing. They undertake tasks that are beyond their own capacity, as I said before, and they are unable to sleep for long, if at all they sleep. And they are too busy to eat. Even if you give them food on a plate, they will pick once and walk as they chew. Even if they are too busy, they wash one leg and they are off. Then, this kind of failure to have food, proper food intake, and the overactivity makes them, at the end of the day, to lose weight. At the same time, they have pressure of speech, and this pressure of speech is characterized by flight of ideas. They talk about this, talk about the other, talk about the other. In fact, in most cases, some literature describes it as a grasshopper mind. Here, there. So they have flight of ideas. Then heightened self-esteem, in which they overrate their own capacity. Heightened self-esteem. They feel they are big, they feel they are rich, they feel they are energetic, they are beautiful and handsome. So they overrate their own capacity of things that they can do. They believe that they are wealthy. Sometimes they believe they are holding high positions in life, and then they are people who are strategically placed for success and to overcome any obstacle that man can encounter. Then, at the same time, they believe they are better than other people. They have outstanding physical and intellectual capacities, and therefore they engage in extravagant expenditure. They can go to a hotel or a restaurant and order food for everybody, even when they don't have the money, only to ask them to pay, and they will talk about a dollar account, which they have in a bank sometimes, which does not even exist. Then they have expansive ideas, and these expansive ideas may sometimes, in severe cases, become full-blown delusions of grandeur. Delusions of grandeur is when a person has exaggerated sense of self-importance. A person may believe even that he's a head of state, he's a chief, he has heads of cattle, he has many wives, he has many children, he has a lot of wealth, all taxes belong to him. That's when the person has the delusions of grandeur. Then in appearance, these people are sometimes overdressed in bright colors, these shouting colors. They are their choices, actually. They have overdone fashions. These overdone fashions may even be having extremely short pants and exaggerated hairstyles if it is a lady. But sometimes this, if it becomes severe, these exaggerated hairstyles, overdone fashions, the person ends up losing hygiene, and then they end up unkempt in case the person develops severe mania. Then they have increased libido. Increased libido, which is characterized by inhibited sexual desires. Increased sexual desire that are also characterized by inhibited sexual acts. They don't mind how to do it and when to do it, as long as it is done. If it is a male, they may rape or even attempt to rape, and for that matter, they tend to conflict with the social norms of society, cultural norms, and sometimes they even conflict with the law. Then they have increased risk of sexually transmitted diseases like HIV, hepatitis B, and the rest. Then these patients may have also hallucinations. A hallucination is a perception without an external stimuli. And in this case, the hallucinations that they have commonly are voices. Voices, and these voices this time enforce their own delusional belief. If at all he believes he's the Kabaka of Uganda, then he will have voices praising him. You are wonderful, Magulu Nyondo, Chuchu, Nantawechwa, as the Baganda say. They will have voices. If it is he believes is Jesus, then he will listen to people having prayers and praying to him to offer them mercy. And then occasionally they may have visual hallucinations, and these visual hallucinations may be of religious nature or supernatural powers. The person may say, "I've seen an angel," and or "I've seen God," and such kind of appearances. Okay, so lastly, we are going to talk about the management of affective disorder, in this case, the management of mania. And our management of mania is summarized in the following statements. 1, we have elevation of hyperactivity. These people are always restless and hyperactive. We want to alleviate hyperactivity. The second thing, we have to alleviate delusions. And the other thing, we have to alleviate hallucinations. And at the same time, we have to restore normal sleep, because these people have reduced need to sleep. And this is a very big problem that may end up even them having accidents. So we have to restore normal sleep. And then we prevent aggression and possible injury to others. Remember, it is least likely that these people will commit suicide because the future has a lot to offer. They are optimistic. And therefore, in most cases, the injury is to others other than themselves. And then we prevent aggression. And then lastly, we want to prevent possible injury, if at all, to themselves and maybe to the people with whom they are living. So we've discussed affective disorders, and we described the definition of the affective disorders. We have also talked about the causes of the affective disorders. We described the signs and symptoms of the bipolar affective disorder, and then we narrowed to the signs and we described the manic episode, and then we have also outlined the management of a manic episode. When we come again, we are going to discuss the depressive episode in another video. Now, before we end our discussion this time, we have an assignment. And this assignment, in one page, I want you to do the following. 1, write the topic, which is affective disorder, this time mania. And then write 5 statements of the things that you have learned, the lesson that you have learned in this discussion. Of course, you are going to use the summary notes that I'm going to send to you, and use the notes that are present on the Moodle or that you have got on the mails. And then write 5 things that you have learned from this lesson. I don't expect you to list symptoms, to list all these things that are found in the notes. I want you to think and tell me the implication. What have you learned? What lesson have you learned from this? And then write 5 things, statements. Write 5 statements of things that you expected to find in this topic, but at least you are disappointed. In other words, you have not found them. Write 5 things that you expected, but you have not found them, either in my discussion or even the available notes. And then you write also 5 major things that you should not miss while managing a patient with a manic episode. I expect you to send me this work in 1 page, and it should be font 12, New Times Roman, 1.5 spacing. So you are going to send it on my mail. When we are interacting with the WhatsApp on these very topics, I'm going to give you a mail where you are going to send me this work. And I expect this page to be having 15 statements. The 5 of the things you have learned, the 5 of the things you expected to learn or to understand but you have not learned, and then the 5 things that are cardinal, that are very important while managing a patient with a manic episode. Thank you very much, and I hope to meet you again in another discussion. Thank you very much.